I'm Yafel Serulle. I'm one of the neuroendovascular physicians in our group at Lenox Hill. And I'm particularly based in one of our satellite hospitals, Phelps Hospital in Westchester, where I'm leading the neuroendovascular program. And then I'm based out here, but I spend 2-3 days a week at Lenox Hill. So my practice is divided between the two hospitals. Today I'm gonna take you through some of the the kind of stuff that we do in neuroendovascular surgery. Neuroendovascular is a subspecialty of neurosurgery in which we do minimally invasive techniques to approach vascular pathology in the brain. And I'm gonna specifically be focused in one of the common things that we do every week, which is acute stroke treatment. And we'll talk about that. Before we continue, please follow me on Instagram and Twitter. I put a lot of cases. So I'm gonna give you guys 30 seconds or so to add me. And then I'll be watching out on my Instagram and see how many of you are gonna be following me. So don't forget to do that. So what I'm gonna do today, I'm gonna first talk a little bit about acute stroke. And then I'm gonna spend a few minutes on that. And then I'll tell you the kind of things that we do to cure a stroke. And then I'm gonna take you into an actual case that we did recently and that we filmed the whole case. So sort of like a live case we're gonna do. So ischemic stroke, put it very simple, in a very simple way, is when an artery that goes into your brain gets occluded. So you have an artery, this artery brings blood into the brain, and then there's a clot then that completely occludes the flow of blood into the brain. When that happens, obviously, the brain dies. And a stroke is a very common, a fairly common disease that we see in our day-to-day practice. It's the fourth leading cause of death in the US, but more importantly, it's the #1 cause of adult disability. From a personal perspective, I will tell you that one of the reasons why I came into the field is precisely to treat these kind of diseases. When I was about 15 years old, my grandmother, that was, back in the mid-90s, suffered a stroke. She used to live with us, and we were at the dining table. And I saw her how she became completely dysarthric and became completely hemiparetic. That really caused a big impact on me. And then I saw how over the next, few years, she, her quality of life obviously, became very poor, and she eventually passed away. Unfortunately, at the time, we had very little options to treat a stroke. Would she have been a patient nowadays? I'm 95% sure that her outcome could have been completely different. So, for a lot of you who are at this stage in your life where you're trying to decide, what to do, think about the things that really move you. Think about the things that really get you excited. Think about those things that you think are really catching your attention on day to day when you are trying to choose what career, to do, either in medicine or something else. And here is a cartoon with some anatomy. Hopefully some of you are somewhat familiar with this anatomy. This is the brain, and these are the main arteries that go into the brain. This is the internal carotid artery, and this is the middle cerebral artery. Clots come in all sizes, so you can have a small clot that occludes a small vessel, but you can have a large clot that then occlude a larger vessel. And of course, when you have a large clot, your infarct is going to be, much larger. The problem with a stroke and when you get a clot in the brain is that time, is of essence. Initially, what you have is a core of infarct, which is a small amount of tissue that dies. And then surrounding that core is a tissue that is susceptible to die, but has not died yet. And the problem is that core of infarct quickly expands within, the next couple of hours after the clot arrives. That is the main reason why we want to take the clots when we are at this very early stage. So going back to that historical context, and I think this is very, very impressive to look at the history of a stroke because it's a field that has really evolved over the last few years. If you were to have a stroke in 1994, there was really no treatment. I just told you about my personal story of my grandmother who precisely in that year had a stroke. There was really no treatment you could offer. The patient would have a stroke, you would give the patient comfort of care. That was it. In 1995, there was one drug that came out that it's IV TPA, which is the clot busting medication that you give IV intravenously. And that was the only drug that we could give for over 20 years. The drug is good. It's not great, it's good. It probably recanalizes about half or probably more in the 30% range of patients. It gives you chances, or 25% of patients give you the chance to recover. And that's basically since 1995 up to 2015, that was the only drug that we had available. Now, in about 2013 to 2015, in this time range, our field of endovascular stroke treatment really took off with multiple trials that appeared because industry came up with a lot of really cool devices. One of them called an aspiration catheter, the other one called a stent retriever. And these new devices led to a lot of trials that really demonstrated that endovascular treatment of a stroke is the most superior way to treat a stroke when you have a clot. And this is a depiction here of one of these devices called a stent retriever that basically goes into a clot, attaches to the clot, and then retrieves the clot. I'm going to show you a video so that you understand what is the concept of the procedure that we kind of do. This is the person's brain. This is the clot that you have here. And then what we do a tiny incision in the groin of a patient. We could also do it from the artery in the hand here, but traditionally we have done it through the leg. We then thread a wire into the aorta, and then through that wire, we thread a catheter. And then we try to go all the way from the groin, initially first into the chest. We're there advancing that catheter into the patient's aorta. We get to the level of the heart. This is where the heart is. And then we try to select the artery that goes into the head. In this case, we have a clot in the left side. So we are going to we're going to catheterize the left common carotid artery, and we're going to make our way into the patient's brain from here. So first of all, we're going to get to the common, this is the neck here. As you can see the patient's face here. We're going to traverse with this wire and this catheter, and we're going to try to make our way to get to this clot, as you can see there. Of course, in real life, this takes a lot of maneuvering, and you need to be very, very careful that you don't perforate any of these arteries on the way to the clot. So a lot of fine movements with your hands to get there. At this point, we're going to bring a very small catheter that eventually is going to get to that clot. And the whole idea is that we're trying to attach this catheter to this clot so that we can remove the clot from the patient's artery. As you will see in the next few seconds, we're going to make our way here. We're bringing this small catheter first here, and then we're going to bring the larger aspiration catheter here. Once we attach to the clot, we're going to remove this catheter. And what we're going to do, we're going to hook up the end of this catheter, which is outside the patient at this point. We're going to connect it to an aspiration tube that's going to go to an aspiration pump that is outside. It's on the operating table. And that pump, we are going to turn on that pump, and then we're going to try to aspirate this clot from the patient. Very similar to what you would do when you're doing some vacuum cleaning in your house, if you have ever done that. Except that in this case, we're in the patient's brain, obviously. So we're just aspirating the clot, and eventually that clot is going to be aspirated. And then, as you can see, the clot comes here, and then the blood is restored. So that kind of treatment became the standard of care in our field just a few years ago. basically in 2015, end of 2015, that treatment was approved. So now, of course, if you were to have a stroke, at least we have another procedure that really increases the chances for you to be recovered. And I just want to emphasize that acute stroke in our year 2020 is no longer a disease that, there's nothing to do about it. It's really now a surgical disease. Every large vessel occlusion that we get in the brain is a patient that we could bring to the interventional suite, and it's a patient that we could offer, the chances to recover. So a big 180-degree, of results thanks to these tools. So I'm not sure if we have questions, but we can proceed now to the case that I'm going to present today. And I just wanted to give you that as an introduction so you have an understanding of the kind of case I'm going to show you. This was a case that we had a few months ago. This was an 83-year-old gentleman who had been admitted to the hospital for a vascular surgery in his belly. He had an embolectomy in his abdomen, but he was doing well initially after surgery. But the day after surgery, he became completely unresponsive. So of course, when a patient becomes completely unresponsive, you're always scared or always worried that there is something going on in the patient's head. So that patient was, a stroke alert was called in the hospital, and that patient was taken emergently to the CT scanner. This is a scan that we call a CT perfusion scan. And what this is telling us is what portions of the brain are lacking blood flow. And as you can see in green, these are the areas of the brain that are not receiving enough blood to sustain the work of the brain, basically. And as you can see, both the left side is as if you are seeing a patient from the feet to the head, and you slice the head, and you're seeing in green all this area that in both sides of the head, this patient is not receiving any blood. This was very highly suggestive of an occlusion, not only on one side of the brain, but in fact affecting both sides of the patient brain, which in the stroke world is something not very typical. Typically, we have only one side, but in this case, we had two sides of the brain completely occluded. So, of course, the first thing is that you need to act very quickly in these cases. And now I'm going to take you into the case. So what we did here, we at this point, we have placed our patient here. Well, you're going to see a couple of cameras here. You're going to see the patient in the interventional suite in the operating room. And this is me, myself, and one of our partners here, Dr. Ortiz, which you probably have met or will meet at some point very soon. He's our chief of endovascular at Lenox Hill, and this is one of our fellows here. And at this point, we knew that the patient had occlusions in both sides of his head, and we needed to open up both occlusions. So we put the patient on the interventional suite. We had already gained access into both groins. We went with two different accesses so that one of us would go into one side and retrieve the clot, while the other one would take the clot on the other side. And that was for the sake of the speed. Remember, every minute that the clot is present in the brain is a minute that the brain is not receiving any blood and therefore is die. So what you're seeing here, the way we work in endovascular procedures, we work from the groin. This is me here, as you see, with the catheters, similar to the cartoon that I was showing you before. And then we're looking at the screen. We're here at the level of the chest, and this is when we are selecting here the arteries of the neck. We're trying to go into the patient's neck here. Very similar to that video that we showed you. And we're first accessing the right side. This is the right side. As you can see, what I'm doing here, I'm advancing that catheter all the way into the neck very carefully, as we spoke about. And then in the meantime, we are going to do the same thing with the other side on the left. So at a given time, you are going to be looking at some images here in a few seconds. And what we are doing here, this is just a flush bag that we put usually to keep these catheters flush with saline, because if you don't have them flush with saline, these catheters will coagulate with blood. So while I'm working and doing some housekeeping on this side, we have my partner accessing the other side and doing the same thing I was doing here. Now he's doing on the other side. And here comes the second catheter. As I said, one catheter is already on the right, and now we're going on the left. And as I said, in the interest of time, we're trying to access both sides at the same time so that we can start getting those clots out of the patient's brain. In every of these procedures is not only the operators who are here, you have a fellow, of course, who's training, and then we have our physician assistant right here, who's a very important part of these procedures. Most typically, we don't have two attendings in one of these procedures, it's only one of us, but because of the two clots here, we decided to do it together. But more typically, we would do this one attending with the physician assistant who's here, or sometimes an attending, the fellow, the physician assistant. It all depends on which case we're doing. So here, going back to the case, we're gaining access now into the left side. Sometimes this may be a little complicated in older patients. Their vessels are more tortuous, so it's not as straightforward to just put a wire and catheter. Sometimes it requires some maneuvering to get to it. And as you can see here, that catheter is going all the way to the head. We are advancing that. You see with that hand, advancing the catheter over a wire. And at that point, we're getting into the patient's head. So now we have located both catheters in the patient head, and we will be ready very soon to take the initial pictures to really understand where the clots are located. Typically, we start each of these procedures by kind of like getting a lay of the land, understanding where the clots are, getting a roadmap of how the vessels look. And now we're getting ready here to do that injection of contrast. Typically, we work on two planes, meaning two screens at the same time. One screen is right here. This is a camera, sort of. It's II, an image intensifier. There's one camera that sees the patient from the frontal aspect. And then we have a second camera here, which is this screen here, that looks at the patient's head from a more lateral perspective. So we have two views here, what we call frontal and lateral. And now we're doing our first picture. And as you will see here very soon, we're getting ready for that picture while doing it simultaneously. This is the first picture, and you can see here the internal carotid artery in both sides. However, we see clots. Right here, there's a clot, and right here, there's a clot. So all of this area of the head on the right side and all of this area of the head on the left side right now are receiving no blood whatsoever. So now that we know where the clots are, we are all getting ready, preparing the tools needed to get the clot out. So as I said, now we're looking at our screen right here, which is the same thing that we're looking at here. We saw that there are clots on both the right side and the left side. So now that we know what we're dealing with, we can prepare the exact tools that we need to take those clots out. So what's happening right now is that we are preparing some things. Our PA went to another table that is typically behind us that you don't see with the camera right here. But that table is where we get, we have a good range of tools there. And what we're doing now, he's getting a lot of these tools ready. Specifically, he's getting a stent retriever, an aspiration catheter. And what I'm doing there, I'm getting ready to insert the aspiration catheter. So what we do with this image here, we create a roadmap image and leave it on the screen there. So this allows us to kind of manipulate our catheter and understand exactly where we're going to stop. So the plan that we have already spoken about in this case, between Dr. Ortiz and I here, we have decided to approach here, coming with an aspiration catheter, come here and put a stent retriever, which is a stent that can retrieve the clot. And then we're gonna do this one first, And then as we put the stent retriever here, which you're seeing right here, we're gonna start also working on this side in just a few seconds. So the first thing we did, we got to the clot is here, and we traversed the clot with a wire so that we can deploy a stent retriever. What the stent retriever does is it allows the clot to integrate in this stent retriever. And in the meantime, we're gonna keep that stent retriever there for approximately 3 minutes. And then through this catheter that is here, we're gonna start aspirating with the pump that we spoke about. As you can see, that here we have the right side, so we leave this here, and in the meantime, we're gonna do a very similar thing on the left side. We are advancing that catheter, and I'm manipulating the catheter. Dr. Ortiz is manipulating the wire here, and we are going to do the same thing. Just pay attention here, the hand movement, trying to get there. And then once we see this, we start here, the same thing. We traverse the clot. We have traversed the clot completely with the wire. And now we're gonna bring, as I said, the smaller catheter all the way here. And then we're going to also deploy a stent retriever, which we will do very soon now. Again, now I'm analyzing here the situation on the right side and see if there has been any changes right here. So you can see here, I'm manipulating now the right side, and then switching to that left side. We're gonna go there too, and we're gonna also hook it up to a second aspiration pump. This is all probably gonna take about 3 to 5 minutes on each side. And as you can see, we even have a timer here in a room in the procedure, so that we could see how long or how much time it has gone by since we deployed the stent retriever. At the same time now, at this point, what we're trying to do here, we're trying to, as we aspirate here with the catheter, we're trying to push back and forth that catheter to sort of try to remove or help it remove the clot. I'm gonna go at a little faster speed right now for the interest of time. And as you can see here, what I'm trying to do here is pushing that catheter right here, sort of that it can swallow that clot, and we can then retrieve that clot out of it. And now we're getting ready to remove that catheter and see if we were successful trying to remove the clot. In the meantime, remember, we have kept the stent retriever on the other side, and now we have completely removed the aspiration catheter from the right side. And now we're gonna do what is called a run. Now we're gonna check if we got any good result. And in fact, we have opened up a little bit the right side. If you compare the initial thing here, now we have opened up all the way up to here. So, you know, not a perfect result yet, but we are very happy that we were able to recanalize a portion of this artery. So at that point, we're very optimistic that if we were able to get that portion of the clot, it's just a matter now of getting more distal, more farther out in the patient's brain to get to the next clot. And now we're going to do the same thing we just did on the right side. We are going to do it on the left side. We are removing now the stent retriever. We aspirate it, and now we're going to get ready to see how we did on the left side. And very similar to the right, not a perfect result yet, but we have really destroyed and removed some of the clot. But of course, some of the clot still remains, so there's still some work to do, but we're very happy that after our first attempt here to remove the clot, we have removed some portion of it. So what we're doing now, you know, we are getting ready for that, you know, second attempt to go to each side. So I'm doing the same procedure that I just did before, all over again. I'm going with that catheter back into the right side to remove what is remaining. And then in the meantime, we're also gonna do the same thing on the left side. As you can see, now we're going back into the right side, and we're gonna bring that, that wire. The clot is now somewhere here based on that image that we had taken after the aspiration. And we are very hopeful that we could remove that clot. Of course, if you were to stop here, you have improved somewhat, you know, the situation, but you're not anywhere near where you really want to be. With the current tools that we have nowadays, we can go into even smaller vessels now and try to remove all the clot that is there. And as I said, we went here, and now we're also going into the left side here to try to remove the clot on the other side. And I'm gonna fast forward it a little bit. And here we are then working on this side right now, trying to do the same thing. In a lot of these procedures, you know, there's always a question, you know, for every possible challenge, there's always, you know, several things that you could do. So a lot of these procedures, sometimes it's about selecting the right tool versus, you know, selecting the wrong tool. Sometimes this can be a very, you know, a deal breaker in any of these procedures. So for every single problem such as this one, you have, you know, the chance to use several things. So a lot of the thinking that goes when we're doing this, it's about which one to use. And keep in mind that all of this is happening in minutes, and you have to be doing this as quick as possible, but of course, you know, as safe as possible as well. And at this point, this is very good. We have really gotten, I think at this point, 80% of the clot on the right side. There's one area of the brain that we noticed that was still getting no blood. And you see right here, that area right here is still getting no blood from the right. But I think at this point, we have recanalized approximately 80 to 85% of the cerebral vasculature on the right. So we're gonna, you know, aim to really find that clot right here that is here, that we know is occluding here. So some work to do. And in the meantime, of course, we have some work to do on the left side. And there we are going now on the left and see if we have made any progress on the left side. We're getting towards the end of the procedure, sort of, because I think at this point, you know, we're kind of like targeting the much smaller clots. And right here, I'm on the right, he's on the left, and we are going to see if our last attempts here, I'm trying to chase that clot that we see on the right. And at the same time, you see here on the left is getting better already. And in the meantime, we have this one here, trying to get that last piece of clot on the right side. We're gonna see the results very quickly right now. And a lot of it is the discussion as well, trying to see what other things we could use on this side, because this side, the clot was a little bit more resistant than on the left. So we're trying to figure out, you know, what tools to use on that side. And I think at this point, we've made a decision of what tool to use. And then we're going back on the left, and then trying to get the clot from there as well. Then I'm gonna forward a little bit to see that final result. At that point, I think we have gotten complete recanalization on the right, and nearly complete recanalization on the left, with just very tiny component right here, which I'm gonna forward here a few minutes. And I think there's a final picture right here. You're gonna see that we successfully treated. And as you can see, we're both very happy, everyone, very exciting here, completely recanalized as well. So very, you know, pleased we were with that final results, seeing complete recanalization and, you know, complete recanalization on both sides. A lot of camaraderie here. This is really teamwork. It's something that you can only achieve when you work with great partners and great, you know, staff in your lab or in your angio suite here. And there we're doing what we call a common run together. And you can see now complete recanalization of the whole brain. Now, this patient who came with clots that were completely, and now everyone is really happy right here, and very, very happy ending. And that's the end of the procedure. When we finish, basically, all you need to do now is take these two catheters out of the patient's groin, and we then put some closure devices on the groin. As you can see, we're scrubbing out. Probably not yet. We still have to close the groin. I think the excitement at the time is very exhilarating when you do these cases. And as you can see, the excitement in the angio suite. Now we're just removing the catheters from the patient's groin, and very soon we will just use some closure devices to close the groin. So I'm gonna then show you what happened with this patient. This patient was completely unresponsive prior to that surgery. And going back here, this is what happened. Catheters in both sides, just summarizing this part. Clots on both sides, completely recanalizing the procedure. These are the people who were on this procedure, completely recanalized. And this was the patient actually 2 days after the procedure. So this is as impressive as it gets. The patient is already reading his text messages on the phone when I went to see him. And, you know, very, very, very impressive, very rewarding procedure. And I hope you guys enjoyed that case. Just one more thing, mechanical thrombectomy, which is the procedure I just showed you, when you compare it to a bunch of other procedures, is probably one of the most effective procedures in all medicine together. This is effectiveness in context. This is numbers needed to treat. This is a measure or a metric that we use a lot in epidemiological studies to determine how many numbers do we need of a certain procedure to have an impact in a disease. So for example, if you look at the flu shot that many of you are familiar with, you need about 71 people vaccinated with the flu in order to prevent that one single flu case, which by all means, it's considered to be a very powerful number. For example, if you look at aspirin in acute infarction, the number is 42. When you look at thrombectomy, the number is only 2.4. This is an amazing number. This is an amazing technique. And as I said, you guys are seeing the field basically being revolutionized over the last couple of years, thanks to the advent of all these techniques. I want to thank you again. This is really exciting to be able to share this case with you guys. And I hope that I have inspired you. And I hope that, by the end of this talk, you guys feel excited about the field, or equally excited about this kind of procedures, equally excited as I am every day. And as I said, when you were trying to choose what to do in life, you cannot choose things based on, what is, the best job out there, or what is the best gig, or what is this. You have to do it based on what excites you. You want to come to work every day. That if this is my job, I mean, my job is to do this, and for me, it's as fun as anything else. I could be skiing, or I could be doing this, and for me, both are equally fun. So you have to find something in life that, when the time to do your work comes, your feeling is not a job, but is your passion, and that you are very passionate about it. And if I can get some of you to get excited about this, I'm gonna be very, very excited myself about it. So I'll leave it here. And I'll, we'll take, questions and or comments, whatever you guys want to shoot. I'm happy to answer.
I'm gonna open the chat now. Can you see the chat for yourself on Zoom?
Yeah, let me see here.
You could stop sharing as well if you want.
Okay, let's sharing. All right, perfect.
All right, the chat's open. The questions come in very fast.
Okay. I can see. Let me see where we start. So Okay, aspiring MD PhD here, definitely going to follow you. Perfect, perfect. Great. Can a severe ischemic stroke lead to death? Absolutely yes. That is an absolute yes. If you have, if this patient that I just showed you, if this case, first of all, if we don't do this case, this patient is going to die. There is just no question about it because there's no blood going into the entire head. But I will go beyond this. If you don't do it quickly, this patient could have died. And if you don't do it as quickly, but you still do it, this patient wouldn't be texting his friends or his family 2 days later. He would have been significantly disabled. So this is an absolute yes. And that's why when we talk about a stroke, we always talk about time. Brain is, time is brain, brain is time, time is brain. And, every second that passes by when you have a stroke is extremely important. The quicker you get to the hospital with a stroke, the more chances you're going to have to be saved. So definitely, for the MD PhD person aspiring to be MD PhD, great. It's a great field. We need a lot of research in our field. So MD PhD is a great thing to have, and it's a great asset for you to have. So good luck to you. Reach out to me if you have any questions about the field and specifically. What happens if you rupture an artery when threading the catheter through? Very good question, and in fact, is one of the known complications of these procedures. That is why you go through a lot of training before you are able to do these procedures independently. What happens if you rupture an artery is that the patient is going to have a brain hemorrhage. So you are in the artery, you ruptured it, and now you have a brain hemorrhage. So if that were to happen, you need to then close the artery. You need to immediately coil it and sacrifice the artery. So the whole procedure becomes moot in a way because you're no longer able to save the artery. And then, many times the patients could die out of this. You have to go to the OR and probably decompress the brain and just give the patients some room to breathe in the brain. And that is a very known or very well-known complication of these procedures. But, in the right hands and the right tools, this kind of complication rarely happens. That being said, as an operator, you have to be ready to observe if these complications were to happen. How do you navigate a catheter to go the way you want it to? Well, that's why you use the screen. That's why you use cameras. And what happens that you are not, I don't know if you could appreciate in the case, but there's a lot of very, very fine hand motions. If you look at the way we manipulate the catheters from outside, we're doing a lot of these motions, and a lot of this is getting used to those tools. And as I said, this is nothing you learn in a month or 2 months or a year. It takes years to develop this kind of skills, and that is how you navigate these catheters. What is this subspecialty called? The subspecialty has evolved over the years. Started called neurointerventional radiology, interventional neuroradiology. Now it's become a very multidisciplinary field. As a whole, it's a subspecialty of neurosurgery called neuroendovascular surgery. Endovascular referring to the fact that you cure diseases of the brain by endovascular means. And what procedures do you do? I just showed you one, which is a mechanical thrombectomy, but we do a bunch of other things, including treatment of brain aneurysms, treatment of brain arteriovenous malformations, treatments of carotid disease, and so on. You use a CT perfusion scan to determine blood flow to the brain. What would you be able to, would you be able to use a SPECT? The SPECT has been used in the past. It's a very good question. The problem with a SPECT is that to get a SPECT, it takes you probably about several hours. The CT scan that I showed you takes you literally less than a minute. You put the patient on the scanner, and within a minute, you get the pictures that I just showed you. If you were to do that with a SPECT, it'll take you several hours. So for our purpose in a stroke, when we're trying to take decisions in a matter of minutes, the spec does not play a role. We do use the spec for other stuff in our field, but not in acute strokes, in the acute stroke setting. How difficult it is to learn to maneuver the catheter. As I said, takes years, to develop the technique. A lot of it is understanding your tools. When you go through this training, the first thing you need to do is understand the pathology. You have to understand the human brain. You have to understand the blood vessels. You have to know your anatomy. You have to know your disease. Then the next thing is that you have to start understanding the tools that we use to do this. What material is this catheter? What material is this other? Why does this catheter behave like this? And why the other behave the other way? And then finally, you start developing those hand skills as well. So altogether, it takes years. I think some of the questions are addressing or trying to ask how detrimental it would be to miss the clot or the tiny clot. I think the big thing is to get the big clot. That will get you probably 80% of where you want to be. Getting the tinier clots are probably going to get you to that 100%. So I think whenever you see those tinier clots, you really need to get them, because once you're doing all this effort, you want to really be 100% when you can. Radiation, someone's wondering about radiation, and yes, radiation is a concern when the procedures are very long. And when I say long, when they go for several hours. Very rarely we get to that point in these procedures. From the operator perspective, people like me who spend almost every day doing these procedures, there's a lot of regulations in our field to make sure that as an operator, we are not exposed. First of all, the current machines that we use are very different to the machines in the past. And I think this is a great question for those of you thinking about the field, but probably thinking, wait, but I don't want to be radiated every day. So the current machines do a great job decreasing radiation. We are completely covered with lead the whole time we're doing these procedures. Not only our bodies are covered, but the emission of x-rays are covered in the room by very stringent shields that minimize, and all of that minimizes the radiation. And the more, as you advance in your training, you learn to do these procedures with very, very little radiation. All of us also have radiation markers, so things that measure our radiation in our shields, so that every month we have something here that we give to the radiation officer in our hospital, and they measure how much radiation we're getting. If for whatever reason that radiation would get to a level that is not optimal, they would let us know, and we would try to correct what's wrong. I will tell you that in my professional life, it has never happened yet. So, with the current tools that we have nowadays, radiation is really minimized. A lot of questions here. How I got into the field. I spoke a little about, how when I was, in my teens, or, in the early 90s, my grandmother suffered a stroke, and how that kind of like lingered in my head. And then later on in med school, when I was exposed to these kind of procedures, I realized that this is what I wanted to do. As I think happens in many things, a lot of your personal experiences are going to translate in what you choose to do in life. And that is important. You need to have an inspiration in life. You need to be inspired by something. And going back to what I said, you need to make it your passion. You need to make it a hobby. You kind of just go to work every day and thinking that, oh, I'm going to work. You need to think of everything you do at work as a passion, as something that you draw a lot of pleasure from doing. So how long did that procedure take? That procedure was on the more complex side, because there were two sites that we needed to recanalize. That entire procedure that you saw there took less than an hour. So with our current tools, I would tell you that an acute stroke with one clot, in the simplest of cases, it would take 10 minutes, literally 15 minutes, no more than that. Once the patient is on the table, once the patient is on the table, and it's a very straightforward case, you can do the groin puncture that we started with, put the catheter in the patient's head, remove the clot, all in about 11 minutes. Of course, that's on one extreme of simple case. In many other cases, the procedures can prolong to a couple of hours in the worst case. So it really depends on the procedure. I would say the average time that we spend in these cases nowadays is probably in the 20 to 30 minute range. What is actually ischemia? Ischemia is lack of blood flow into the brain, basically. Or not into the brain, to any tissue. It's lack of blood, basically, lack of nutrients. That is what ischemia is. Did the patient have any disability as a result of the stroke? This patient actually recovered by the second day after the procedure. The patient was almost fully recovered with some mild facial weakness. By a week after the procedure, the patient was completely recovered from the stroke. So the patient did not have any disability from this infarct or from the stroke. How common are bilateral strokes? I show you this case, so it's very dramatic, but this is probably 1% of the cases we do. The most typical case is going to be one-sided stroke, a clot that will go into one side of the brain and you will remove it. Not the case in this bilateral stroke. So very rare, but I think worth showing and worth going through. How did you get such a mastery of the cerebrovascular anatomy? I think this goes back to the question of training. You have to read a lot to get to that point. You have to understand a lot of the anatomy, and that takes years. As I said, this takes years. You start learning anatomy in med school, even before, depending on your major in college, and that only, you just have to continue basically learning and learning. I'm still learning myself of anatomy variants. Cerebrovascular anatomy can be very challenging because not everyone is wired the same way. There's a lot of variants of those vessels in the brain. And unfortunately, those variants have a lot of impact in what you do. So for every case, you have to be very aware of what are the connections of these blood vessels. Because if you are trying to embolize a blood vessel for a given procedure, and that blood vessel has a connection that is not typical, let's say, you may end up embolizing the wrong vessel and producing a bad outcome. So learning anatomy and learning its variants is something that is very important in the kind of procedures that we do. And it's something that even I, with years of practice, years of training, continue to learn every day. Someone asked if I have ever had an unsuccessful case. Absolutely. Unfortunately, what we do is not perfect, and we as human beings are not perfect. And I will tell you that it's very hard when you get an unsuccessful case, but the way I learned from my mentors and the way I approach this is every time I go into a case, I try to do the best as I can and just hope for the best. You do your best, you hope for the best. If the outcome is not good for whatever reason, either, it was, in the case of a stroke, it was too late, or the anatomy was very challenging and I couldn't get to the clot, or the clot was very hard to retrieve, all I need to do, or all you need to do in this case is just try to learn from every case that didn't go well. In fact, from the failures in cases, those are the times when you learn the most. And I think that this applies to life as well. It's in those times when you fail that give those are when you're given chances to learn. And from every of these cases that is not successful, you just have to like do your best and learn from it. Why start the catheter at the groin? That was the way. There are two routes right now that we use to start catheters from. We can either use the groin or we can either use the radial artery. The groin is a great place where to start because the femoral artery is very large. So you can put a lot of tools, a lot of big catheters through it. And it has a very simple way to access it. Very few arteries in the human body are going to have the size of the femoral artery and are going to be readily accessible to it. So those are two features of the femoral artery that make it very good for these cases. Okay, we have a few minutes left. What is considered by neurological improvement in the Norvan? Yes, great question. We use the modified Rankin scale to understand neurological improvement. The modified Rankin scale, it's a measure of how independent are you to perform tasks of daily living. So it's a scale that goes from 0, which is a person like most of us right here, who could go and do everything yourself. And it goes up to, the higher you get, the more, the more dependent you are on other people. So for example, if you have a modified Rankin scale of 3, that means that you may need someone's help to do certain tasks, such as cooking or something like that. So this is a scale that, you can look it up in Google. It basically consists of several questions that you ask the patients, and then you kind of determine that number. And this is what we use to sometimes understand the clinical outcome in these cases. Is it comparable to saving a life? Well, it's not a one-to-one comparable, but it is comparable with quality of life more than saving a life. So why can you go directly from the brain to retrieve the clots? That's a great question. Basically, to retrieve the clot, you have to be inside the blood vessel, inside the artery. That would be extremely hard to do with an open brain surgery, let alone the time it will take to get to that blood vessel. Remember, these blood vessels are pretty deep inside your brain. To get there, you would have to remove the skull. You would have to slowly retrieve brain tissue bit by bit. And that is something that you don't do in minutes. That's something that's going to take hours, let alone trying to get into the blood vessel then and getting the clot. We have time for a couple more questions.
I'd say I think we should wrap it up here. Give everyone
okay, perfect.
To use the bathroom and take a little break before we start the next lecture. But thank you so much for joining us.
Yeah, great discussion. Thanks for having me. If you guys have any other questions, just reach out. I'm happy to chat.